Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Nahabalata from Roots Community Health Center, reporting for the week of January 24th, 2022. As health professionals rooted in Oakland, serving some of the people most vulnerable to getting and suffering from COVID-19, we are here to cut through the noise to give you information you can use that will keep you, your loved ones, and your community as safe as possible. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. Please submit your questions in the comments, by direct message, or by email to admin@rootsclinic.org. As of January 23rd, there have been 70.7 million cases of COVID nationwide that have been recorded and 866,000 deaths from COVID-19 in the United States. And it looks like we are starting to see a decrease in cases, not in every area. We know that every area is going to be hit a little bit differently and at different times, but those that were hit early, like DC and New York, appear to be ticking down a bit, which is welcomed news. And so overall, the 14-day average does appear to be coming down just a bit for the United States overall, but daily deaths continue to increase. And we are still seeing a couple of thousand people dying a day. We're still really hitting records. Here in Alameda County, we've got 446 individuals in the hospital with COVID-19. And remember, the worst day in our winter surge last year, so before we even had our vaccines available, really, we had 454 individuals in the hospital. So we're not far from that. But again, hopefully we'll be turning around and coming back down. But right now, this is a pretty concerning level that we're at here. Also got, of those, 68 are in the ICU. So far, 1,578 individuals have lost their life to COVID-19 here in Alameda County. Of those, 452 were Oakland residents. And out of that 1,578 deaths, 313 were in skilled nursing facilities. You know that I've stopped reporting deaths every single week for a little while now because the numbers were starting to definitely come down, but now we are seeing them tick up just a little bit. So I will be reporting on those now as we continue to monitor the impact of this winter surge. In terms of vaccination, we are doing great in this county compared to a lot of other places in the United States. Overall, we have 80.9% of Alameda County residents fully vaccinated, and only about, though, 55% are boosted. So, of course, aiming to get those numbers up, especially now with this Omicron surge. And the good thing about getting that booster dose is that it really is restoring the effectiveness of the vaccines to a really pretty decent rate in terms of protecting from Omicron. And it becomes effective pretty quickly. So just after a few days, you don't have to wait those 2 weeks before you're considered sort of fully protected from that dose because it is a booster. It's taking effect pretty quickly. So something worth doing if you've not done it yet. The lowest vaccine rate in terms of age is still our 5 to 11-year-olds. We've got just 47.4% of that age group being fully vaccinated. And I know we're all hearing it, kids getting sent home and whatnot for testing positive, or households where the child is positive. And oftentimes, unfortunately, what we're hearing is that, oh no, that child has not been vaccinated yet. And so certainly we know that although children tend to do better when they catch COVID-19, we do still have some children getting very sick with COVID-19, being hospitalized, even going to the ICU. Certainly long COVID is a reality in children as well. So we really do want to avoid our children getting COVID-19, but also with their vaccination rate being that low, we also are concerned that they will be contributing to the continued spread of COVID-19. And so we also want to be mindful of that. In terms of race ethnic groups, Again, compared to that 81% of the county overall. Both African American and Latino folks within the county are a full 15 points lower at about 65 to 66% fully vaccinated. So again, when we have pockets of the population that are not as well vaccinated, then we get concerned about greater transmission within communities, within schools, within households, and so on. And so, as we continue to progress, we are going to be more and more focused, I think, on the remaining unvaccinated, because although we know that really anyone can spread it, those that are most likely to succumb to COVID-19 are those that are not vaccinated at all, as well as those who did not mount a good response. So I've been getting a lot of questions about if I don't feel well with COVID, do I really have to get tested? But even more so, if I test positive, am I going to be eligible for treatment? I'm getting a lot of different questions, and I thought I would just take kind of a little step back here and go over what I'm just going to call COVID-19 pharmaceuticals at this point. And so we've got, I mean, really, it's kind of remarkable when you think about what a short time we've been dealing with this, and how much we have been able to actually develop that is targeted against SARS-CoV-2 and its various variants as well to some extent. And so we know that the first and foremost and most important and broadest protection, most complete protection, is really going to be the vaccine. And there really just isn't any replacing this. This is what is going to give your body that sneak preview so that you will be ready if you get hit with the real thing. And to really, it really has continued to do what it was designed to do, which is to stop the most severe outcomes from COVID-19, hospitalization and death. And it is continuing to do that. And so, really, ideally, hopefully, most of us can just stop there at that vaccine, and not ever need any of these other things. But this is sort of the full array of what we've got. We've also got treatments that are pre-exposure. We call that pre-exposure prophylaxis. And I spoke about this in a little bit more detail in the December 14th, 2021 briefing. And this is a product called Evusheld. It is 2 intramuscular injections that is really designed when you're not infected, you're not recently exposed. It gives 6 months of protection, and this really is to folks that have significant immune compromise, where they really need that extra protection from doing poorly with SARS-CoV-2. And so this is really for a select group of individuals, 12 and up, that do have immune compromise or not expected to have mounted a good response to the vaccine. And so that is something that is available. Now we've got post-exposure prophylaxis, and so that what that is that we've got some of the monoclonal antibodies. Of course, we know that some of those that were effective against Delta are not effective against Omicron, and we're mostly dealing with Omicron now. But nonetheless, at least in theory, there's this availability of monoclonal antibodies after you've been exposed if you're at high risk of doing poorly. And this is something that has never been in super great supply, simply because the priority would be to treat individuals. But there has been limited availability in the past, and I'm pretty sure there will be availability of it in the future. Right now, it's a little tough to get your hands on any of these things that I'm talking about, pre-exposure, post-exposure, and also outpatient treatment. But those are, hopefully March, April, around that time. Unfortunately, it'll probably be after this particular surge subsides, but nonetheless, we're still in it for a minute, so we're going to want to be keeping an eye out for these different types of pharmaceutical treatments in the event that they are needed. Now, the outpatient treatment, I have spent some time in past briefings talking a little more detail about the pills, the Paxlovid, the molnupiravir. We've also got some infusion treatments, the sotrovimab, which is the monoclonal antibody that does have activity against the Omicron variant. There's also remdesivir, the one that was really only for inpatient treatment for the majority of this pandemic so far, but now is actually being recognized as a viable outpatient treatment. It is also an infusion, so you do have to go get it in an infusion center. So not necessarily the most convenient thing in the world, but nonetheless, those are our outpatient treatments. And again, none of them are in great supply right now, but they are available. And I'm going to go into a little bit more detail about who they may be available to. And then I think we're all fairly familiar with inpatient treatment. It's really at that point oxygen. There are some antivirals, the remdesivir, as well as, if needed, intubation and mechanical ventilation, steroids as well. And so, we don't want to get to this point. So we kind of don't want to get to any of these points if we can avoid it with that first leg right there, the vaccine. But if you get sick enough, you go to the hospital, then you're going to need treatment. This last one here, there's still just a big question mark there about long COVID and what kinds of treatments are going to be needed right now. A lot of it is just based on what kind of symptoms are presenting. There certainly have been reports of new onset diabetes after COVID-19, respiratory challenges, cardiovascular issues, neurological issues. And we don't know. It's just too soon to know. In fact, there are a number of viruses that we've later found out, like HPV can cause cancer. We didn't know that right at the beginning. And so we really just don't know. So, not to be alarmist, but it just causes such a constellation of issues. And there's a lot of research going on right now around long COVID and what those treatments might look like. But really, I think two main points I want to make here with all these COVID pharmaceuticals. First of all, just want folks to be aware that there is this array of things available. Hopefully, if you get the vaccine, you'll never have to deal with any of those other ones. I think also for people who are thinking they can maybe dibble and dabble in some of these other things and not get the vaccine, I just would encourage you to challenge your own thought process around this. Many of these are made by the same manufacturers. They go through very much the same vetting process, the same safety reviews, the same clinical trials. And so I would just challenge you to answer the question for yourself: why would I agree to a treatment and not agree to the vaccine? So we just want to kind of check the logic there a little bit. And certainly with the vaccine, we can reduce the need for any of these other things, and ideally keep everyone out of the hospital and out of that danger zone. And I think the other reason why I wanted to sort of bring this up is to let you know that pre-exposure prophylaxis, post-exposure prophylaxis, and outpatient treatment, even though they're not too available right now, they are available for those who need them most, and they will become more available in the future. But I could tell you that it is going to be very difficult to get it if you don't have a primary care doctor. And so, I know that I talk about this on the briefing a lot, but if you don't have a primary care doctor, please get one. You deserve to have your own expert in your own corner, someone that you can call and someone who takes responsibility for getting you the right information and the care that you deserve. So I've gotten a lot of questions about, okay, if I was to test positive for COVID-19, would I be eligible for treatment? And this is in part because, as I reviewed last time, we were really wanting to think about how are we to manage everything when there is a shortage of testing, the turnaround times are getting longer. We've got these home tests. We're not sure if we should rely on them. So when should we test and why? And what I went over was this graphic here, which essentially showed that, yeah, if you're going to a gathering or traveling or you're recovering from COVID-19, then really the antigen is going to be the most useful test. And I went over that in some detail last week. But if you've got symptoms or you may have been exposed, how you then proceed, particularly when there are shortages of testing supplies and access, how you proceed is going to be based on if you're high risk or low risk. And that's because if you're higher risk, then you may be eligible for treatment. So, how do you know if you're going to be eligible for treatment? So we'll just walk through this a little bit. So if you're higher risk, then that is when we're really going to want you to be prioritized for the PCR test. And we are going to want you to get those definitive results as soon as possible because many of the treatments need to be started immediately. Paxlovid, really the most promising of all the treatments, needs to be started within 5 days. And so if your PCR test result doesn't come back for 6 days and you are already on day 2 of symptoms, then really you're no longer eligible for that treatment, or it's not as likely to be effective. The monoclonal antibody treatments, which are in short supply, you've got to take within 10 days. So still kind of a tight window there. And so expanding upon this graphic here, I wanted to show this. So if the branching point here is, are you high risk, yes or no? And I'm going to go into what that means right now, because unfortunately that's a little bit of a moving target as well. But if you are high risk and you are experiencing symptoms, then we want you to get that PCR test right away. And if you're positive, you know what to do. You isolate, tell your contacts, and you look into your treatment right away. And like I mentioned, I really hope that if you're in this category, you have a primary care doctor that you can contact and say, hey, I just started with symptoms. I'm on day 2. I got my PCR test. I'm positive. What can you do for me? And hopefully they will be able to call in a prescription for you of Paxlovid or refer you to the infusion center for outpatient, either sotrovimab or even remdesivir. And so all of these things, the availability is sort of improving with every day that passes. And so we just need to be our own best advocates and ask about these things. And if you're negative, the PCR test is pretty good when you've got symptoms. So if you've got symptoms and you get your PCR right away and it's negative, then you're pretty much done with the testing. You should continue to take good care of yourself. You don't want to go around others if you've got some kind of respiratory illness, because most of them are contagious. And obviously seek care if you have a worsening condition. Now, is the PCR perfect? No, but it's not the kind of thing that you need to repeat if you had symptoms when you got the test. Now, if you were exposed, this is when it's a little trickier, but if you're high risk and you're exposed, then we still do want you to get that PCR test. You can do it in a few days. We used to say 3 to 5 days. With Omicron, it's looking like it's a little sooner to really replicate there in the nose to where you'll have a positive test. So after a few days, again, get that PCR test, and pretty much the same. If it's negative, if you feel like you did it too soon, there is an argument that you could repeat it or repeat an antigen. But again, this PCR test is pretty sensitive, and so it's one that we feel fairly comfortable relying on, with the caveat that if you do it too soon, that it still may not have turned positive just yet. Now, if you are in the lower risk category, I'm not going to go through this one in detail, but really in this case, if you're not going to get treatment anyway, then really your decision is based upon whether you, first of all, if you can just do an antigen test and you can isolate. If the antigen test is positive, you really don't need to go get a PCR test. And so the only other, major caveat I think to this would be if, let's say, you are the primary caregiver for someone who would do poorly if they caught COVID, you really, really need to know for sure, because you've got to be around them. You're still going to wear the N95 mask. In this case, you may want to go ahead and get the PCR, just to be certain, but it also doesn't hurt to get the antigen test before you go around this person you're caregiving, let's say, and just make sure that you're not very contagious. So posted the link to this in the post. And so if you want to take a closer look at this, please do. But I think the bottom line is that how we decide to make use of scarce testing resources is really somewhat predicated upon how we're going to be making use of scarce treatment, which is the next issue. And so how are we thinking about who gets prioritized for treatment? the NIH has really made a pretty nice prioritization scheme, which is very helpful for prescribing physicians. And what it does, and this is adapted from the COVID-19 treatment guidelines panel's interim statement on patient prioritization for outpatient anti-SARS-CoV-2 therapies or preventive strategies when there are logistical or supply constraints. Logistical or supply constraints. So you see, this is a theme here. So, but I really do appreciate that the NIH gave some guidance, because you really just hate to be out here trying to figure out what to do when there's not enough. And so the fact that they gave some solid guidance is very, very helpful. I also put the link in the post. It's kind of a lot of information. It really is for prescribers, but since I've been getting so many questions, it's something that you can certainly take a look at. Now, tier one, this is going to be if we really don't have very much at all and we've really got to conserve. Who does the NIH consider the most at risk? Well, anyone who is immunocompromised, and again, that is because they may not have mounted a good response when they got the vaccine, but also anyone who is unvaccinated over 75 or unvaccinated over 65 plus risk factors. So this is who is getting prioritized for this scarce treatment. And this should tell you something. This is who we are most worried about. These are the people that are most likely to do poorly if they catch COVID-19, and this is who is being prioritized. Now, if we've got a little more available, then we can go down to tier two, and that's going to be everyone that has a clinical risk factor, regardless of their age, or unvaccinated over 65. Then if we have even more available, and so on. And so the tier four, and I think a number of places are already able to prescribe in tier four. Tier four is going to be anyone who has clinical risk factors, even if they're vaccinated, and let's say that they are vaccinated but not boosted. Also, everyone over 65, or anyone of any age with any risk factor. And so basically what I would say is that if you are in tier four, so if you are over 65 years old, or if you have any clinical risk factor, I'm going to get to those in a sec, I would be advocating with my physician to get treatment if you catch COVID. So this is the tier structure, and again, this is meant to guide clinicians when there's a shortage. But this should be something that you can also think about as a guide for yourself, to know that, okay, I'm in that high risk category. I would say anyone that's in that tier four, and essentially you should be advocating to be treated if you have if you're COVID positive. Now, will it be available for you when you need it and on time, and will your doctor get it for you? Those are all those factors that the if you have a doctor, you're in a much better position to be able to advocate for yourself for this. This is why we always tell people, even before COVID, don't wait till you're sick to try to find yourself a doctor. You need one ahead of time, because then really you've got someone who can advocate for you. So what are the underlying medical conditions? Well, these also they're changing a bit, and they're changing based on the amount of evidence that we have coming in and how good the quality of that evidence is. And so I put the link in the post to this CDC page, which is what the NIH is using to guide this prioritization. And so you can see underlying medical conditions associated with higher risk for severe COVID-19. And this is, again, information for healthcare providers, but it is available there on the CDC website. And they kind of broke this down into a few different sections. One is where there is very strong evidence, and the next one is sort of less of a quality of evidence, observational studies, and then the third category is actually where there's sort of mixed evidence. But the summary of conditions with evidence, this is pretty solid evidence, some kind of a systematic review or meta-analysis where they take a number of different studies and analyze them together, and can come up with a strength of a conclusion. And there are a number of conditions here, and a number of them that are quite common, really. So it's not only cancer and chronic lung and liver and kidney disease, but history of stroke, cerebrovascular disease, diabetes, type 1 and 2 diabetes, very common, certain heart conditions, mental health disorders. Those include mood disorders, schizophrenia, and even depression. Again, very common. Obesity, very common, extremely common, even more common now than ever with the pandemic. Pregnancy and recent pregnancy. Smoking, current and former smoker, extremely common. So, a number of conditions here that have evidence that they will put you at risk of doing poorly with COVID-19, and again, would put you into that tier 4, regardless of how old you are, for potentially being prioritized for treatment should you catch SARS-CoV-2. And so it really has been challenging, I think, for all of us. Even though we all knew we were going to have a winter surge, maybe we didn't know it was going to be this big. We hope we wouldn't be losing so many lives, hoped we wouldn't have so many people in the hospital. But of course, hope is not a strategy. We have to have a strategy. And right now, to be in the beginning of 2022 and not have enough things, not just having constrained resources, whether that is tests or whether that is treatment, is certainly very challenging. And I think, if nothing else, it really leads to back to the same conclusion that I think we keep coming back to, which is that it takes multiple layers to protect us, and that we're going to have to implement all these multiple layers. And those include thinking about being strategic about our resources, but also what can we do to make our environments safer. And so we already know we want to vaccinate and boost, and certainly the most vulnerable are the completely unvaccinated. But at this point, the booster really is going to be necessary to give that level of protection, and particularly for those who had their primary series some time ago, or for those who are elder or who have other underlying conditions. But really, at this point, it is recommended for everyone just because of the hit that the effectiveness took when it came to Omicron. We want to continue to embrace outdoor activities, and certainly for the next several weeks while we're still in this large surge. I think if we can kind of survive these next few weeks, that's that's a thing. That's definitely something. And so I would encourage us to postpone maybe some of those indoor gatherings until we get to a more reasonable level of transmission, because right now the transmission is quite out of control. And it's not going to be like that forever. So I think if we can hang on a bit, that's a thing to do. Make indoors safer. And I do think this is something we all need to be turning our attention to. I spoke in some detail about this last week about the workplaces, but this goes for every indoor space. We need to be thinking about ventilation and filtration, and how to really invest now in infrastructure for our businesses, our schools, and all of the places that we're going that are indoors, to ensure that they are held to a higher standard, because our indoor air quality, I don't think we've ever thought so much about indoor air quality, but we need to be doing more about it, not just thinking about it or hoping. We need to actually be investing in the infrastructure of our buildings to make our indoors safer. We need to test strategically. We need to also treat strategically. We need to isolate. We need to contact trace. We need to go back to the source. Where do we think we caught it? And who do we need to notify so that hopefully we can stop the transmission to the greatest extent possible? And then, of course, those high quality, high filtration, well fitted masks. All masks are not created equal. I had some questions. Well, what do I do with all these cloth masks I bought? Should I just throw them away? And I'm calling those outside masks, or they're the masks you can just pop on when someone's at the door. When really what you're worried about is droplet transmission, and you're not worried about the accumulation of aerosol within your enclosed space. So you don't have to throw them away, but really, if you're going to be in an indoor space, at this point, the recommendation really is a well-fitted N95 or KN95 mask. And of course, we want you to eat a balanced diet, get some fresh air, some sunlight, some exercise, and get some vitamin D, a multivitamin, keep your stress levels down, get a good night's sleep. And thank you so much for joining us. We will see you next Tuesday at 10 a.m. See you then.